Last 3 weeks was we have covered all the basic radiology, parameter sciences, temporal bone, and this week we are planning to cover the radiology of head and neck. Hope we have served our purpose. So I welcome Dr. Shajit P, Secretary Magenta Society, to give the welcome address. Over to Dr. Shajit.
Good evening. As you know, we are conducting Magenta for last 7 years. Unfortunately, we couldn't do it properly, but anyhow, we could do with the help of WebEx and all online platform. Anyhow, we could gather around 200 participants, and we could gather all the good faculties. This time we have eminent faculties like Arun Patatayil. We know Arun. He studied from Calicut Medical College only. He is our own colleague. Later on, he completed from Amrita. Now he is in Tata. He will be enlightening us with the surgical aspect of radiology. So we welcome you, Arun. Next is Dr. Sandhya. Sandhya is new to this END fraternity, as you know, but she'll be enlightening in a good manner. Welcome, Sandhya ma'am. I also welcome our State Secretary, Paul. He is our own colleague. Welcome, Paul. And we also welcome all the delegates in and around India. We would like to welcome all of you for this last and final Magenta 2020. Thank you.
Next is felicitation to Magenta 2020 by AOE Secretary Dr. Paul Salman. Over to Dr. Paul.
Thank you. Hope I am audible.
Yes.
Yes.
Good evening. Good evening, everybody, respected senior members, faculty for the day, and dear friends. As we're here on the third day of Magenta 2020, I feel very privileged to be given an opportunity to offer felicitation in this great academic fiesta. As we all know, we are gathered here not only in the spirit of academic pursuit, but also to celebrate the great life of our dear M.A. Gopalakrishnan sir. Gopalakrishnan sir was an evergreen and vibrant presence in the academic events of Otolaryngologist of India, Kerala chapter, as well as in our country. Magenta is definitely a befitting tribute to this great soul who was and who continues to be a role model to all the END surgeons. Just as his presence was there in almost all academic events of the state during his time, I am sure those who know him can feel him in our midst. Memories are still fresh, they don't die. AOI Malappuram is well known for its camaraderie, and they are working very hard every year to make this program an epitome of academic brilliance. This year, even COVID could not weaken their commitment and perseverance. I congratulate all AOI Malappuram members, especially Prabharan sir, our AOI President-elect for Kerala State, Dr. Mansoor Kurikal, President of AOI Malappuram, Dr. Abhilash Alex Francis, Secretary AOI Malappuram, Dr. Shajit, Secretary of Magenta Society, Dr. Mohammed Sayer, who is the Secretary for this conference. I'm sure a special word of mention has to be given for this great online platform which they have arranged for this great event, and it surely is a big success. Let us all strive to keep the flame of academic interest burning bright. And as Secretary of AOI Kerala, I exhort all our END colleagues to stay safe and stay healthy during this COVID time. Enjoy the sessions. Thank you, one and all.
Words. Next, I would like to invite Dr. Mohammed Sayyid, Organizing Secretary of Magenta 2020, to deliver the vote of thanks. Over to you, Dr. Sayed.
Good evening.
Good evening, sir.
Good evening, dear friends and senior colleagues. Today is the third and final session of Magenta 2020. At this moment, as organizing secretary, I would like to thank all the people who are part of this event. The Magenta Society and AOI Malappuram ENT chapter are extremely thankful to Dr. Sanjay Ved, who is an internationally acclaimed head and neck radiologist, and Dr. Neelam Ved, a well-known ENT surgeon and cochlear implant surgeon from Pune, who gave us wonderful sessions as faculties in Magenta 2020 in the last session. We extend our thanks to Dr. Arun Pattatayil, a reputed head and neck oncosurgeon for Tata Memorial Hospital, Calcutta. He was my senior at Calicut Medical College and I was doing his MS during my DLO course. And he was the best student and role model for all hospital students at that time. I am happy to see him as faculty in today's session. Special thanks once again to Dr. Arun. And we thank Dr. Sandhya, a renowned radiologist from the prestigious Amrita Institute, Kochi, as faculty in today's session. We are very happy to extend our thanks to Dr. Manoj MP, who is a well-known otologist, cochlear implant surgeon, head and neck surgeon from Calicut. He helped organizing committee beyond the role of a faculty. Thank you very much, sir. I thank profusely Dr. Shajid for doing all the planning and groundwork for the excellent show of this event. I personally thank Dr. Abhilash for his coordination skills and for smooth running of this webinar. Organization committee would like to thank EventGuru for their professional service and giving a wonderful platform to make this event a grand success. I also thank Sandosh Surgicals, Karelka Surgicals and Allied Meditech for participating in this program with their virtual stalls. With great gratitude, I thank all the distinguished delegates for your participation and interactions to make this event as a memorable one. Thank you once again. Jai Hind.
Thank you, sir. With this, we'll start with the basic session. I would like to welcome Dr. Arun Pattatayil and Dr. Sandhya for this event.
I'll start first, Abhilash.
There's a small introduction. Dr. Arun is currently the senior consultant of head and neck surgery from Tata Medical Center, Kolkata. He completed his DLO from Calicut Medical College in 1998, MSc from the same Calicut Medical College 1999. He finished his MCH head and neck surgery from Amrita Institute of Medical Science in 2007. He was awarded a research fellowship from NI National Institute of Health, Bethesda, Maryland, USA. He has pioneered establishing the head and neck oncology services prestigious in Tata Medical Center in Eastern India. He is also the chief of the Head and Neck Translational Research Initiative at the Institute and the lead member in setting up a biorepository for cancer specimens for future research. He is also a mentor and supervisor students for a 2-year specialty training in head and neck surgical oncology. He has many publications in many peer-reviewed journals. Also held the post of Deputy Editor of Journal of Radiomaxillofacial Trauma and Reconstruction, and also as an invited faculty and presented research papers in many national and international conferences. His special interest is head and neck surgery and oncology and research. The next speaker for the day is Dr. Sandhya. Welcome, ma'am, to this gathering. She is currently the Associate Professor of Department of Radiology, Amrita Institute of Medical Science, with a vast experience of 13 years. She did her MBBS from Government Medical College, Thrissur in 1989. The MD Radiology from Western Medical College, Jodhpur in Rajasthan, and has more than 15 publications in many peer-reviewed journals in the field of head and neck oncology. She has delivered original scientific work and invited lectures in many national and international conferences. The special interest is in head and neck imaging. Thank you, ma'am. Over to you, sir.
Dr. Arun, you can share, right? I made it the presenter. Hello. I shared my
Hello.
screen and it should
Yeah.
Hello. Yes.
Yes, sir. Yeah. It's
It's coming.
coming. It's coming. There's a slight lag, but it's coming. Low bandwidth. Low.
I
We
fear
noticed some internet issues at your Dr. Arun. Your internet is kind of not stable. That is the issue.
Yeah. We can hear you, but it is kind of broken actually in between.
Can you stop share and share again?
Green ones. There you go.
No, you are the presenter.
Kindly do stop share and do the sharing once again. It will be fine.
Yeah, sir, please. Once again.
Yeah, no, I'll unshare you and then I'll give you share access again. Okay. It is actually, yeah, 1 minute.
Yeah. Yeah, I'm able to see.
Yeah, 1 minute, 1 minute. I'll make you this 1 minute, 1 minute. One second. Okay, you can make it now. Yes, sir.
Right,
Yes,
are
sir.
you able to see my
Yes, sir.
screen? Am I audible? Am I audible?
Yes, sir.
Yes.
Your voice is
So
clear
thank
and
you.
your screen is visible.
Thank you, Magenta Society, for having me here on the screen. It's a privilege, and I was looking forward to this even for quite some time. And that is when COVID struck. It's a very good opportunity to come back and the people with whom I grew up in Malappuram and Code. Thank you, Dr. Prabhakaran, Dr. Mansoor, Zair, Shajid, who has constantly been in touch with me. And as I said, Dr. Manoj, teacher, friend, guide, philosopher, critic. So we had 2 sessions of Magenta, and I really enjoyed the 2 Veds, Neelam and Sanjay, go through radiology. Made it look more like an art than science. But I think it's that blend of art and science that makes radiology so beautiful, so useful. Sorry for making this look very dramatic, desperately seeking radiology. But I'll take you to where when we all started Magenta. Abhilash had put up a poll saying, how many of you report your radiology? And then I shrank back and I said, no, I can't do it. Headache is a specialty where we have to chase radiology. And whether they report or not, you sometimes, even in spite of having a report, time and again you have to sit with them, go to so population of general practitioners. When it comes to the oncology world, you realize that on your own. I'm just hiding just to feel here. But that is not the truth. You are just only a cog in the wheel. So sometimes you do have, and most of the times you have to reach out to all those components of that interdisciplinary wheel if you have to offer proper and optimal care in cancer. With apologies to Barack Obama, yes, we do chase up the radiologist time and again. One of the key things which we need from radiology is to know that the tumor that the patient has come with is benign or malignant. And I'm sure in your case also, you would have wondered, you've seen that patient thyroid swelling with that swelling below the lobule of the ear, and you wondered, are you the cancer undo? And that is the time when your radiologist comes to your mind. And most of the time you have to refer this patient to them for clarity. As oncologists, letters of the alphabet, the T, N, and M. And anytime you see a patient with cancer, none of our documentation would go without a T, N, and M. And as staging has evolved from, it's a JCC 8 at this point of time, it's important to stage a patient clinically alone. You have to bring in radiology. For example, if you want to say that a larynx is T4, unless it's a grossly extensive fungating disease, there is no way the subtleties of erosion, a little bit of extra thyroid extension, you cannot make it out by clinical examination. So for staging, radiology has become an integral part of our everyday practice. When there are when it's said that a good general knows when to retreat, and there are instances where it's not sane to go ahead, and that would be issues like a skull base where the logistics would change immediately. You alone would be helpless. You would need a neurosurgeon to be on assisting you with these surgeries. Again, a surgeon remove a tumor with an adequate we would have to sit on the console, look at the mark it out, imprint it into your brain when you put your incision. So getting margins is if you think you cannot get margins in an oncology access, there are many ways, but how can we, just for example, let's see, we see these parapharyngeal tumors time and again through the neck. Do I need to split the mandible? Has it got to be a do you need a wider access to reach that? Will it bleed? Do you need a big thing in which, because you have 3D vision when you go into, when you sit on the console. And even today, they can reconstruct all the structure and give you a real what you would want. Interventions. For example, there is this little lung nodule. Is it tuberculosis? Is this a metastasis? No, that is hugely important, because if it is metastasis, you would not go for surgery. If it's tuberculosis, well, go ahead, treat it, and then go ahead. Tumors, embolization, and sometimes we do very small other challenging area is
Hello, sir. Hello, sir. Arun, sir, your voice is not breaking. Arun, sir, your voice is breaking.
it is construction. Can you hear me? Hear me now?
Yeah. Yeah, we can. Maybe you can stop your screen so that bandwidth will be improved. Stop the video.
There is no
Improve
video.
the bandwidth.
Okay.
No, your video.
My video.
And because that will improve the bandwidth.
Do that. I'll do that.
Okay.
Stop showing myself
right
video.
now. You can continue.
Do that.
Yeah.
Done? Is it okay?
Yeah. No, actually, yeah, it's
Can you hear me now?
Yeah, we can hear you, so you can continue.
Okay, so I don't know where you lost me. Maybe I can continue from where you lost me. So Abhilash, can you just guide me?
Yeah. Just after the intervention, sir. After the
Yes, that is
intervention.
it. So again, post-operative follow-up is a huge challenge. These are days when we put in reconstruction and resection go hand in hand, and we put those humongous flaps to cover up so many defects. Are you able to hear me now?
Yes,
Yes.
you can hear.
Yes.
Okay, and most of the time your eyes can't see, your fingers can't palpate, and that is the time when radiology comes to the fore to help you. So many indications. It's impossible even after practicing oncology for more than 15 years and looking at scans all the time. We do have to seek out Dr. Sandhya time and again. So with that, we move on. I'm stuck here.
EventGurus slide is not moving.
My slide is not progressing.
There is some problem at your end, sir. I mean, you are supposed to be moving the slide, right? Not,
Yeah, it is not moving.
or maybe you will have to share and can you wait?
Yeah.
It's not moving at all.
Wait, just a minute. No, didn't move. Can you see my mouse?
No. Maybe can you unshare and share or something? You have internet instability is there. That's why the.
So shall I move on to another network then? Shall we see if that works?
That would be better. That would be better.
Let me try. I'll try to move into another network and see if it works.
Sorry for the inconvenience. There are some technical glitches. We are just switching over to another internet connection. Please bear with us.
Hear me?
Arun sir. Arun sir, you're on.
Yeah. Now, can you hear me now?
Yeah, we can hear you.
So I've changed the network. I hope it works this time.
Can you do the sharing?
I'll do that.
Can you hear me?
Yeah.
Hello, can you hear me?
EventGurus, yes.
Yeah. Now it's sharing.
Yeah.
You can hear me, right?
Yeah, I can hear you, but he's currently sharing the screen actually.
Yeah. Dr. Arun, can you stop video? Not stop self video. Stop the video. It is the second button from the right at the bottom. Just stop your video to save some data.
Hello.
Yes, sir, Arun sir.
Okay, I'm sharing, right?
Yeah, if you can see a button stop video in the downside of the laptop, just press it so that it will increase the bandwidth. Next to the mute button.
Yeah.
Yeah, we can see your desktop now. I think you have to share your PowerPoint.
Okay.
Right now we are seeing the desktop.
Okay. So I'll stop sharing again and
Yeah.
I'll share once again.
You have to
I'll
open
share
your PowerPoint.
my
and-
PowerPoint. Yes. That's it. Right? Is it
Yeah.
clear now? Better?
Yeah, right now we can see you.
Right.
Yeah. Okay, sir. Go ahead.
Clear? Screen is good?
Yeah, screen
Okay,
is good.
great. Okay, so with that, I will get into more specific areas. So this is perhaps thyroid surgery is perhaps one of the first head neck surgeries, or one of the favorite head and neck surgeries among practitioners. And as budding head and neck surgeons, it's probably one of the first surgeries that you would do. Usually, while evaluating thyroid nodules, there's a classic 3 tests which you would want from every patient. The first would be an ultrasound, and Dr. Sandhya will tell you how an ultrasound would help us with planning our treatment and in planning our surgery. We also have to resort to a pathologist who would probably do an FNAC, and there also you will need the help of a radiologist to identify nodes, characterize nodes, and probably guide in the needle into an appropriate location, and a thyroid functional test. But sometimes this nice, good thyroid, it starts behaving badly. And that is the time when you want the radiologist to help you with cross-sectional imaging. In my book, I would do cross-sectional imaging for a large tumor. But believe me, sometimes even if the tumor is large, even if it is small, they do tend to be invasive. So it's all in the biology. It doesn't usually mean that a small thyroid is usually good. We have got stuck with smaller ones, which are very, very invasive. You again will rule out whether it's not going below the sternal notch, or it's not going retrosternal. But thyroids do take that route. And there are thyroids which come with lymph nodes. Again, of local invasion like hoarseness, or a documented recurrent palsy. When you scope these patients, you see that one cord is not moving, or you find that it's stuck to the skin and the patient has difficulty in swallowing. Or again, one of the features of distant metastasis to usually to the lumbar spine and to the lung, and the metastasis to the bone would present as pain and probably radiculopathies. So these are occasions when we would go beyond the classic 3, which I've highlighted in red, and go for cross-sectional imaging. So I would now seek Dr. Sandhya's help at this point of time. And Dr. Sandhya, here we have in the clinic a patient who have come with a nodule, young girl coming in, and then you really want to know whether you want to go ahead with the surgery or not. So will you help us to let us know what is the nature of this nodule? The biggest question the patients come with is the cancer or no, right? And so how do you assess it? How do you let us know what are the risk features in a thyroid nodule? Over to Dr. Sandhya.
Share.
Welcome, ma'am. We are seeing your screen. It's just coming on.
You can see the
Yes,
screen.
madam. You are on.
My voice
It's
is
ready.
all the organizers and Dr. Arun for inviting me for the program. So I'll start with the answers to the questions he has asked. So for thyroid, it's the most important modality because the texture of thyroid can only be analyzed only with the help of ultrasound. And the CT MRI is recommended only when there is an extrathyroidal extension. If it is invading into the surrounding structures, it's going down into the mediastinum, want to assess the mediastinal nodes, CT MRI is useful. So without ultrasound, you cannot go ahead with in thyroid imaging. And for recurrent tumors and all, that we'll see in the end. So ultrasound, this is a normal ultrasound picture of a thyroid. For doing an ultrasound, you require a high frequency probe, especially for thyroid and all the superficial organs. You need 12 to 18 megahertz probe. Only that can give a high resolution image. So this is the normal texture of a normal thyroid. You can see it is homogeneously hyperintense. And all these are the strap muscles which are anterior to it, and they will all be darker than the thyroid. And on either side, posteriorly, you see the carotid artery, and the center, what you see, is the portion of the trachea. Trachea being covered with air, the entire ultrasound will be reflected away, so we won't get a shadow of the trachea. So this is how a normal thyroid look like. So when you see a nodule, for assessing a tumor nodule, first location of the nodule, then you have to get an idea of the size and what is its texture, whether it is solid or cystic or it's a combination of solid cystic. And what about the margins, whether it is smooth, irregular, and shape, whether it is tall or it is wide, and the nature of calcifications, vascularity, any extrathyroidal extension. Along with that, you have to assess the cervical nodes. So American College of Radiology has recommended a strategy for evaluation of nodule. So that is the TIRADS, and we follow this TIRADS thing for standardizing the nodule. And here I'll just go through the TIRADS. There is TIRADS category starts from 1 to 5. First 1 and 2 are benign, so you need not do any further evaluation. TIRADS tier 3 is mildly suspicious, we need to follow it up. Or do an FNA if the size is very big. And when it comes to TIRADS 4 and 5, it becomes suspicious, so an FNA is warranted. So I'll just show you a few pictures. This is, you can see a dark anechoic thing inside the thyroid lobe. This is a cystic structure. A pure cyst like this with no septa, homogeneously dark. This is a benign thing. So this doesn't require any further evaluation. And another thing is, you see here, this is a spongiform nodule, means we are seeing many microcysts within, small thin ball cyst. And this is a colloid nodule. This also doesn't require any further evaluation. This comes on thyroid 0 benign. And when this is a combination of cyst and the solid, and cyst and solid also, this also comes under benign category. But when the echogenicity of the solid nodule becomes more dark, it will go into the next category. So it might require a follow-up. Here you can see it is a solid nodule. There are no cystic contents and the margins are fairly smooth and the echo texture is matching with that of the thyroid. So this comes under the category of TIRADS 3. And it requires, from TIRADS 3 onwards, we need to do follow-up. And an FNAC if the size is more than 2.5 centimeter. When the texture becomes dark, it becomes more suspicious. Here it is a dark solid thing with a smooth margin, but still it will go into the category 4. And this will require an FNAC when the size is more than 1.5 centimeter. When the margins of this becomes irregular, or when there is fine calcification, you can see here this micro calcifications are usually less than 2 millimeters and very difficult to see, very faint. And when you see this irregular margins, faint calcification, it will go into the highly suspicious category. Then you have to do an FNAC. If more than 1 centimeter, we do it. Even if it is less than 1 centimeter, we do for all cases, TIRADS 4 and 5. We don't leave those cases. And this is again, vascularity is not included in the TIRADS. They say that vascularity suggests there are some viable tissue only. And mainly this PAP CA, medullary CA, and plastic. They are all dark and very much contracted and they don't show much vascularity. High vascularity, what I have observed is more in a follicular carcinoma. It has got a different texture from this, but that can appear sometimes echogenic. It may show abundant vascularity. So that is why from the TIRADS 4 onwards, we have to do the follow-up and FNAC. And these are some of the calcifications we are seeing. These are like RI calcifications, macro, very big calcifications, more than 1 centimeter. These are all usually benign. And here you see fine echoes with a comet-like artifact behind. This is very suggestive of a colloid nodule. These are all benign calcifications. Micro calcifications are very faint and very difficult to see. And when you evaluate the thyroid, evaluation of nodes is very essential. And a normal node will look like this. It will be an oval shaped and will have an echogenic fatty hilum. Fat is usually echogenic and the margins are very smooth. And when the hilum is lost, here you can see that fatty hilum is lost, the size of the node is increased and the texture has become more dark, it becomes suspicious. There can be cystic changes, there can be microcalcification within the node, and you can see here abundant vascularity, especially when it is coming from the outside. Periphery, this is again suspicious. And when you look at the pattern of vascularity here, you can see here and all it is broken. This is all this is a suspicious feature on ultrasound. CT and can I continue, Dr. Arun, on this?
Yeah, go ahead.
CT and MRI are recommended when there is an extrathyroidal extension, when you feel that this nodule is invading into the surroundings. This is a normal CT picture. Usually when we image the neck, we always start from the skull base to the carina in CT, and for MRI up to the root of the neck, because we are along with the region of interest, we have to cover the lymph nodes also. So in this is a normal thyroid. Normal thyroid enhances intensely on contrast because of the large amount of iodine inside and a very vascular organ. And it will be homogeneous. We don't see any ill-defined hypodense areas within the thyroid, a normal thyroid gland. And these are the surrounding muscles, which will be less enhancing than a thyroid gland. In the center, you see the dark air-filled trachea. On either side, posterolaterally, you have the IJV, and this is common carotid artery. And posteriorly, you will see the esophagus also. And these are the prevertebral muscles, and there will be nice fat plane between this muscle, which are much more appreciated in MRI, but a CT is enough for further evaluation in case of the thyroid. This is a case in which you can see that the normal texture of the thyroid is all gone and it has infiltrated into the prevertebral muscles, and here we don't see the common carotid artery and IJV, even the esophagus and the margins, it seems to be protruding into the trachea. Here you see that it is totally, you can see the vessels inside. These are the vessels on the right side, and the left side it is totally encased. When the encasement goes, when it is up to 180 degree, be operable, but beyond 180 degree, that there are chances of addition to the vessels. And here you do, these are the prevertebral muscles, and usually you will see a dark fat plane between these two that is lost. And for retrosternal extension, I think a CT alone is enough. A sagittal and coronal reformats we can make. The CT we do is a volume CT. Then later on from that we can make a sagittal reformat can clearly show the retrosternal extension of the thyroid into the it is going up till the level of carina in this, up to the sternal ankle. MRI is needed when you are suspecting, when there is a subtle invasion into the trachea or the esophagus that may not be well appreciated on a CT. Then we might go, very rarely we do MR. Here, the advantage of a CT is that we can see the mucosa very nicely. See the mucosa and the surrounding cartilage. It has got a different signal. Mucosa is bright and the cartilage is dark. And if any invasion of this into the trachea, you can see there is obliteration of this dark signal and the bright mucosa. This is suspicious of tracheal invasion. Similarly, the layers of esophagus are also can be well out in MRI as compared to CT. And very rarely only we do MR, mostly we depend on CT. Ultrasound is a must for thyroid. After characterization of the nodule, when we are planning for surgery, we go for CT, not MR is very rarely done. So over to Dr. Arun.
There are a few
Can I have my screen?
questions. Sir, can I ask a few questions?
Yeah.
Madam, there were two questions. Like one is by Dr. Hannat. How to differentiate between thyroiditis and Graves' disease in an ultrasound? Can we do it? Can you differentiate any specific features in ultrasound?
Yeah. In thyroiditis, and what we see is a uniform involved. We don't see any definite nodules. There will be uniform enlargement and uniform alteration of the texture. We have already seen the normal texture of the thyroid. That will be lost. It will be very coarse. And you can see varying grades of vascularity. The initial phase, the increased vascularity, and the later on, when it becomes chronic, that vascularity is gone and the thyroid becomes shrunken. We might get a feeling that some nodules are there. It is due to fibrosis, but actually the picture is very different. Ultrasound is a very good modality for thyroid, I must say. Without ultrasound, you should never investigate thyroid.
Another question from Dr. Anushri regarding physiological. How will you differentiate between physiological goiter and diffuse hyperplasia of thyroid in young age? Physiological goiter and diffuse hyperplasia of thyroid.
Both will have the same texture, I feel.
Okay.
The goiter, there will be nodule. There can be nodules inside.
Okay. Only that.
That is difficult.
Okay. Thank you, ma'am. Over to Arun. Dr. Arun.
Yeah. Thank you for Dr. Sandhya for passing on some very key messages. The first message that should go down is that ultrasound is the radiologic modality of choice for the initial evaluation of a thyroid nodule. You would augment it with a CT scan or MRI scan if you suspect that there is local invasion, or you suspect malignancy in that, or there are lymph nodes present. You know, thyroids have a tendency to throw up lymph nodes all over the neck. I have found the thyroid nodes in the paranasopharyngeal space. We had to do a mandibulotomy to get to that. So please do a cross-sectional imaging if you find a thyroid with a clinically positive node. Now, why is it important to know whether the thyroid has gone beyond its confines? It has gone into the prevertebral, or it's gone into the trachea or the esophagus. It's because the treatment modality, the only treatment modality for thyroid is surgery followed by radioiodine. And if you leave thyroid disease behind, it has been shown that people do not do well. So here there are a lot of studies which have said that please don't treat thyroid as benign. Many people say that, okay, thyroid we can mop it up with radioiodine. That's not the case. It definitely has a benefit in terms of survival. DFS is disease-free survival. So the goal of the surgeon should be to remove all macroscopic disease. Microscopic disease doesn't matter in thyroid. It can be mopped up, but the surgeon, what he sees with his eye, what the scan shows, has to be, even if it goes into the airway. You saw some great pictures from Dr. Sandhya where it is seen going into the trachea. There is no question, you can't leave disease beyond. The biggest issue that people face, they call me for, is when it is stuck to the trachea. If you can take it out without leaving residual tissue on the thyroid, save the airway. But if it does involve, you have no way, you will have to resect the thyroid. For example, look here again. See, the black is the cartilage, and the mucosa appears much paler. And here you see it going into that. If you have any doubts on that, augment it with a bronchoscopy, and you would, on the same picture, in the same image, you would find that this patient has nodes. So leaving nodes behind will not complete your operation. You will have to do a thyroidectomy and do a neck dissection as well. So on the coronal plane, you would find the thyroid butting in like an angle into the airway, and these are necrotic or cystic nodes which you see in the neck. And that is a specimen. This is the affected lobe on the left side, which is larger, infiltrative. The left is a normal thyroid, but a few tracheal rings had to be taken off, and the trachea would be re-anastomosed after the disease has been cleared. Retrosternal extension, if you go for a definition of retrosternal extension, you would find many definitions from many quarters. Some would say the T4 vertebra, some would say thoracic inlet, somebody would say it's the arch of aorta. For me, I usually, as a clinical guide, I use the arch of aorta. If it is above the arch of aorta, I would just warn my thoracic surgeon. Most of the time you can pull these lesions out. But again, as I said, it's not the size that matters. It is the invasiveness, the infiltration, which is a problem. And sometimes it gets really infiltrated into the mediastinal tissues, and you cannot pull it through the neck, and you would have to open up the thorax in order to remove them. Nodes in the mediastinum. So always look for nodes if you suspect malignant thyroid. They do throw up nodes everywhere. In this case, if you're opening up the sternum, or usually we go for a clamshell with not a complete sternotomy, you would be able to clear these nodes. So the goal of thyroid surgery should not be thyroidectomy alone, and it should take it off your mind that if I take the thyroid out and leave the rest of the disease to radioiodine, believe it's not going to work. You would have to plow down into the thorax and remove all tissues, at least grossly, before you would send these patients for radioiodine. So that is the reason where Dr. Sandhya comes in with her imaging and tells us whether the thyroid is invasive. You would know how much to resect. You would know how far down you have to go in such situations. So again, the three areas which you would look for is the airway, it's pharynx and esophagus, and retrosternal. So again, I think Dr. Sandhya has already covered the best imaging modality for local extension is she would prefer a CT scan, and sometimes augmented when MRI when it goes into the airway. Now, there was some concern among some quarters about using iodine contrast when you do a CT scan, because people said, oh, it stuns the thyroid, because in that case, the tissues would take up iodine, which you gave as contrast for your CT, and then they may not take up radioiodine when they're treated with therapeutic doses of radioiodine. That controversy has now come to rest. And for the past few years, we are using more of CT scan. We used more MRI because we thought we did not want to give them iodine contrast. But I think a few recent papers in the last few years have said that, no, you can give radioiodine. So go ahead. If you find that you need more information from these thyroid nodules, go ahead and do a CT scan. Dr. Sandhya has again shown us some very good pictures on how to look for local extension. Yet another favorite operations, many that. Are you able to see my screen?
Hello, sir.
Abhilash, yes?
Yes, hello, sir. Your sharing
Yes,
is not, you have lost your sharing. Kindly reshare.
I'll do that.
Yes, it's there now. Kindly make it slideshow.
Right.
Yes, sir. You're on.
Right. Okay, fine. So again, I tell you, it's one of the more favorite head and neck surgeries in general practice is to do a parotidectomy. And to quote a common perception that if the facial nerve wasn't there, taking out the parotid is like taking out a lymph node. No worries. It's a facial nerve that makes surgery to the salivary gland such an art. It is a prospect for people in private practice. It feels so bad when you hit the gland, when you hit the nerve, and the patient comes in with a facial paralysis. If there was no facial nerve, salivary glands would have been a lymph node biopsy. Even as a greater difficulty that we as oncosurgeons face with the parotid glands is that the kinds of pathologies that you find in salivary glands. Just open up the WHO textbook on head and neck pathology and see around 70 to 80 pathologic entities. And most of the time, FNAC is only about 80% sensitive and very, very specific when it comes. It can't, when it comes to saying whether, this is malignant, and if malignant, what kind of malignancy it is. But we will we'll put that matter to rest at this point of time and worry about, is it cancer? And because if it is a malignancy, so what? Most of the 80% of our parotid tumors are benign, and most of them would be pleomorphic adenoma. But why do you need to see? It is important. One, the patient remains informed that this is a malignancy. And secondly, you would look for nodes. You would maybe clear the nodes in certain cases. If it's a high grade malignancy, you would have to do a neck dissection along with that. So it's important by radiology. Radiologist tells you that, hey, you're looking at a malignant salivary gland here. And sometimes, the decision regarding the facial nerve is very difficult. A patient may not have a facial palsy preoperatively, but when you go down to operate, you would find that the tumor is really stuck. You cannot make a plane between the nerve and the gland. If you can make a plane, again, just like thyroid, if you don't leave my macroscopic disease on the nerve, go ahead, save the nerve. The facial nerve is important. And we have seen that that does not compromise on local control or survival in any way. So you can take a facial nerve out of a gland if you find a plain dissection between that. But many a times, surprises are sprung only when you take up this patient. And that would be late in the day when you have tried to save the nerve, you have dissected it, and suddenly it enters into an area where you cannot take it off. And they say, no, I'm done. Let me sacrifice this nerve. And see, the goal should be to reconstruct the nerve immediately. It works. It works. You should learn how to with a suture. It's very easy to get a sural nerve. It's not somewhere deep down. It's right on. Get a sural nerve. Here I have used a split sural nerve. So you don't have to reconstruct all 5 nerves of the pes anserinus or the goose foot, as you say. Just focus on the one which supplies the eye, the zygomatic and the marginal mandibular, which will supply the lip. And here I have used a sural nerve which is split into 2. So the epineurium can be split down into 2. Fascicles can be taken out. And I have used, after the anastomosis, I usually put in a sleeve of vein. That is a vein taken from anywhere in the field. So that is slid over the anastomosis. So it creates a biological tube through which then the nerve could grow. So the issue that we face, and I would like to ask Dr. Sandhya, again, I'm stuck here. Are you able to hear me, Abhilash?
Yes, sir.
We can hear you.
Audible, sir.
I can't move my slide. Give me a second. Maybe I'm just trying to move my slide. I think my network is playing up today.
Can you try from your screen, click the mouse on it?
I'll try, sir. No, yeah, there you go. It highlights, but it doesn't move. Thank you.
Yeah, it's come.
So, yeah. Okay. So again, Dr. Sandhya, you heard our discussion. All those people sitting out in the audience are really, really worried about the facial nerve. They want to save it somehow. So the first question is, can we see this nerve as it goes? Like, we had a session on temporal bone anatomy, and we saw Dr. Ved show us, moving down all the way from the skull base through the genu, and then it comes out to the stylomastoid foramen. Here we are looking at the nerve outside the stylomastoid foramen. We are looking for it in the soft tissue. Can we look for infiltration? And secondly, rather than being caught in unawares in the middle of a surgery, can you say whether the nerve is infiltrated? Can we say that, I can take out the nerve without and leave and take the disease out and leave the intact facial nerve behind? So Dr. Sandhya, your views on this. Over to Dr. Sandhya.
Yes, madam, we can see you.
Yeah. I don't have to say the initial imaging features and all. No, I can directly go to the facial now, Dr. Ali. Can you hear me?
Yeah, Dr. Sandhya, are you speaking to me?
Yeah. I was asking you whether I need to show the initial imaging features of a normal this thing or directly go to
Go
the
ahead, your
facial.
choice, Dr. Sandhya, because if you give us an introduction, maybe, we would appreciate your images better.
Okay.
Yeah.
The thing is, for salivary gland also, the imaging modality is ultrasound and MRI. First ultrasound, then MRI. And what we commonly encounter is all benign tumors. And imaging features, a lot of overlap between the malignant and benign features. It is not, and without histopathology, we can't make a 100% diagnosis that this is benign or this is malignant. But some features which have helped us is in MRI, because the margin, ill-defined margins you get in all this lobulated margins, irregular margins, we get in pleomorphic adenoma also. So what you're seeing is in a T2 weighted image. Is a T2 weighted image. If the lesion becomes dark, there is an increased chance of malignancy. This is an intermediate signal. In this, there was an ectopic, there was an adenoma from this minor salivary gland in the tongue that is looking bright. And when the lesion is bright on T2, there is a less chance. It is more of a benign. It is looking dark, we have to suspect malignancy. And Warthin's has got a very different imaging features compared to others. It can show sometimes bright signals on T1. Usually all the tumors will be dark on T1 weighted MR image and slightly bright or intermediate signal on T2 weighted image. In a Warthin's tumor, because of the mucoid content in more cystic areas, on T1 weighted image, it can give a bright signal. And this Warthin's, and what we usually do to characterize this tumors in salivary gland is we use a diffusion and a perfusion weighted imaging. And diffusion weighted imaging, what we are studying is the Brownian motion of the water molecules within the tumor. That what is happening is when the tumor is highly cellular, the extracellular water, the water movement will be reduced because of the large number of cells. So usually in every malignant tumors, that there will be a restriction in the diffusion of the water molecules. What you are seeing in salivary gland tumors, the Warthin's, even though it is benign, it is showing more restriction than the other malignant tumors. That is a fallacy here. And similarly, in perfusion, we are studying the blood flow and the vascularity of the tumor. In that also, we have seen there is a fallacy that the Warthin's tumor shows a sharp intake. Here, this curve is showing a sharp uptake of contrast and a sudden drop. This is normally seen in a malignant tumors in other areas where there will be a rapid inflow of blood and there will be leaky capillaries. So immediately the contrast index goes out. And this feature, all these malignant features, what we advocate in other areas are seen in Warthin's tumor. So with morphology alone, it is very difficult to differentiate benign from malignant in a salivary gland tumor. The modality of choice is first is ultrasound, then we have to do an MRI. And regarding the question regarding the facial nerve, we always have found it very difficult to evaluate or see the normal facial nerve. What we usually do is we follow it up from the stylomastoid foramen into the gland. And a normal, and here, this is a CT picture where you can see this is the mastoid. And this is the area, this is a styloid process, and this is the area from where it comes out. So every now there will be some fat. So that fat density will be visualized in the stylomastoid foramen. And if it is obliterated, we have to suspect there is a soft tissue infiltration of the nerve. So the course of the nerve is like this. Here you can see in the pictorial this thing. This is the mastoid, and the posterior belly of the digastric is attached here. And this is a styloid process. And in between these two, you see this is a facial nerve going into the parotid. And this is seen slightly lateral to the retromandibular vein. This is a retromandibular vein. So here the vein is always seen very nicely. And adjacent to it, if you see a tumor, you have to think of facial nerve involvement. So here you can see this is the mastoid process, and this is a styloid, and this is the way it comes up. And the normal facial nerve is not seen on CT. On MR also it is very difficult unless it is infiltrated. In a post-contrast image, if this is infiltrated, you can see intense enhancement. Here, this is an MR image where you can see this is the mastoid process and this is a styloid. In between comes a stylomastoid foramen from where it exits. Here you see a dense enhancement, and here even in the brain you have some thickening here. That is suspicious of facial nerve infiltration. Okay. Over to Arun.
Yeah, please activate my share button, please.
Madam, can I take a few questions?
Yeah.
Yeah, one is, madam, already, I think you already showed it's about the relation.
I think we can start.
Hello?
Okay, Abhilash, are you asking those questions?
Yeah, there are two questions.
Yeah.
Go ahead.
One, madam has already told that about the relation of retromandibular vein with the facial nerve, trunk of the facial nerve. Whether when the facial nerve is displaced, we can see whether the retromandibular vein is also displaced. So that can be done. The other thing is, what about deep lobe tumors? How will you about the any specificity for deep lobe tumors, deep lobe parotid?
Yeah, deep lobe tumors, MRI is a must. Deep lobe we cannot visualize on ultrasound. For deep lobe, always MRI is needed for this salivary tumors, because we cannot see the entire area, because that mandible will be a hindrance to image the deep lobe. And surrounding infiltration and facial nerve, everything for which will require an MRI. CT is done only when you're suspecting some calculus or something for salivary glands. All other tumors, ultrasound should be the protocol.
Presence of Dr. Bhargavan from Wayanad, Dr. Sujit Roy, Dr. Sanjay Vaid, Dr. Suma, Dr. Sunil, Dr. Sharafuddin PK, and Dr. Girish Raj, and Dr. Sajid Babu for this webinar. We welcome you all. Arun sir, I think we can go ahead with your.
Yeah. So yeah, isn't it interesting, Abhilash? We never lose our fascination for the facial nerve. It never comes. The sort of ceases bother us. Never ceases to be a wonder for all of us. But thank you, Dr. Sandhya, for elucidating that. And yet another area where head neck, where the ENT surgeon takes on the role of a head and neck oncologist is with tumors of the larynx and hypopharynx. So again, if you go by AJCC 8, we cannot stage larynx without radiology. And that is again when we would desperately seek Sandhya. And because treatment for larynx and hypopharynx used to be laryngectomy at the time we were in Calicut Medical College. Any large larynx, we would take them up for laryngectomy. But for the past decade or more, issues of voice issues of speech and organ preservation have come to dominate the discussion. And we now have robust data, many years of data saying that concurrent chemoradiation, and putting it simply, is giving chemotherapy, usually a cisplatinum-based chemotherapy, along with the radiation, has similar larynx preservation rates compared to laryngectomy, which is considered to be a more debilitating operation. So in order to distinguish, are all larynges suitable for chemoradiation is the larger question. And that is where, you know, a radiologist comes into. You cannot keep all advanced larynx for organ preservation. Just because you have a T3 or a T4 tumor doesn't mean that no T3 tumor doesn't mean that the patient would go for a total laryngectomy. So Dr. Sandhya, so some of these things when we go through the AJCC staging manual would be, you know, is there pre-epiglottic spread? Is there paraglottic spread? Why do you want to know that? Because that would make it a T3 lesion. Or is there a cartilage erosion or an extralaryngeal spread, which would make it into a T4 lesion? Dr. Sandhya, can you just guide us a bit about the anatomy of the larynx? You know, we all see it through the flexible endoscope, we see it through the Hopkins rod telescope, and we see it through our... And then we do have to resort to radiology. There is no question. All malignancy of the larynx undergo some kind of a cross-sectional imaging, either CT or MRI. Please guide us. Tell us a little bit of the anatomy and kindly show us how would you stage these tumors as we go along. Over to Dr. Sandhya.
You
Yes,
can
ma'am.
see that.
Yes, ma'am. Your screen is.
For larynx, CT is the modality because most of these people cannot be able to lie down for a long time. MRI requires a long time, even though the resolution may be better if it is a well cooperative patient. You can get a better image with MR, but we prefer to do CT because MRI takes a long time and the patient is not able to lie down right. So it is not a satisfactory first choice of image. And because subtle mucosal lesions are always missed on imaging. And we'll just go through the anatomy. So actually, the mid larynx you have the true and false cards, and ventricle is a rhesus between the true and false cards. And supraglottis, it refers to the region above the level of, so including the array epiglottic fold to the tip of epiglottis, you have the supraglottis, and glottis refers to the true part, and subglottis starts from the true part to the lower margin of the trachea. So then, evaluating this laryngeal structures, what we do is a volume CT. We will be in every neck case we are covering.
Your voice is breaking in between. Yeah.
Means every neck case we are doing a volume scan from the skull base to vagina, and this is reconstructed in axial, coronal, and sagittal images. I'm audible, no?
Yes, you're audible now. You're audible.
Axial, coronal, sagittal images are regenerated from this 3D data set. And because we can reformat the images in this, is less important as compared to the previous data. And when we reformat, we take a slice orientation parallel to the laryngeal ventricle. Slide is stuck.
EventGurus, the slide is not moving.
Slide, and can you try mouse with mouse or keyboard?
Man, try with the keyboard or mouse, I guess. No, I think the annotation is on. I think the annotation is on.
Annotation is not really.
Yeah. You switch on the annotation.
It's out of control.
No, I'll just remove you and then add you.
Yeah.
Can you do
Yeah.
I'm not sure. I'll just remove you. Okay.
Yeah. We do examination.
Yeah, right.
Quiet breathing. Normally, in quiet breathing, if you try to hold the breath, what happens? Both the vocal cord opposes, so you won't be able to see the limit. So, in quiet breathing, it is done. And sometimes you can do this, many respiratory maneuvers like puff cheek, so that this pyriform sinus and everything will blot up and we can see the all the movement very nicely. And intravenous contrast is always given to delineate the lymph nodes of the blood vessels. Images, the upper slices, so you can see this is the upper cut. Cut at the level of the epiglottis. See, the thin structure is the epiglottis, and the one anterior to that is the glossoepiglottic fold, and medial and lateral glossoepiglottic fold, and these are the vallecula. As you come down, you can see the epiglottis. Epiglottis is a very thin structure which is attached to the thyroid cartilage by thyroepiglottic ligament, also to be hyoid by hyoepiglottic ligament. So, anterior is epiglottis. You see, this fat is always dark. This is the pre-epiglottic fat, which continues laterally to become the paraglottic fat. So, normally these areas are very dark. And on either side, you can see the araepiglottic fold. These are the araepiglottic fold, which will go posteriorly attached to the arytenoid cartilage. So here you can see this is the araepiglottic fold, and this is the paraglottic fat, and these are the thyroid cartilage. A tumor which is involving this area is very nice. The tumors always have a soft tissue density. If it is going into this pre-epiglottic space and the paraglottic dark area, if it is getting obliterated, means that area is involved by the tumor. And the upper arytenoid, you can see that where the arytenoid starts, this is the two dots, is the level of the false start. At that level also we can appreciate a bit of the paraglottic fat. The next level, where the vocal process is very nicely, that is the level of the true chord. At the level of the true chord, the paraglottic fat ends almost because it is all filled with the vocalis muscle. And below that, you can see the subglottis, which is an oval-shaped structure. And you don't see any, even the mucosa is very thin, you hardly see any soft tissue with it. If you see any minimal soft tissue thickening, that suggests that the tumor is extending down to the subglottis. So this is a breath hold image. You can see both the chords aposes. So you cannot appreciate the lumen. Actually, there was a polyp coming here, which was demonstrated when we asked the patient to do a phonation. We always do it in the quiet breath of cheek. Because when we ask to do this phonations, what happens? The patient tends to move and the image becomes blurred. And from where we can do a coronal and a sagittal reformation. And the sagittal slices, the coronal slices, you can see this is the true chord. The undersurface and the superior surface of the chords appreciated in a coronal image. And here this epiglottis, pre-epiglottic fat, this is well appreciated in a sag image. In the sag image, you can see the base of the tongue, any extension up into the base tongue, vallecula, all these are well seen in a sagittal reformation. And the confusion always comes when there is a cartilage erosion. Here, this cricoid, thyroid, and arytenoid cartilages, they can get ossified, and this ossified cartilages are more prone to tumor invasion. And whenever there is a confusion regarding the cartilage invasion, we go for MRI. When overt invasion, when there is an overt invasion, it is easy to, a through invasion is easy to diagnose on a CT. The problem comes when the cartilage is not ossified. And you see this tumor is abutting, and the tumor has got a texture almost same as an unossified cartilage. Only in such cases, when there is a confusion, only we go for MRI, because for MRI, the patient has to lie down for a long time. It is very difficult for them to lie still. So the images tend to get blurred. this ossified cartilage will have a dark outline, white marrow. This is a case in which you can see this is a CT image and these two are MR images. In CT images, there is calcification here and there, and this is an unossified region. And there is a tumor here which is abutting the cartilage, and both have almost the same texture. We don't know whether it has gone beyond and gone into the strap muscles. This unossified area of cartilage on MRI will be totally dark. See, it is dark, and you see that the tumor has got a different signal from the cartilage. Tumor usually will have an intermediate signal on T2. So it is possible to differentiate. It has not gone into the cartilaginous area. So after contrast also, you don't see any enhancement overlying the cartilage. This is an enhanced tumor, and this is suggested that there is no cartilage invasion. But when you come to this case, here you see when there is ossification, you will see two lines actually. You can see two, it's not very clear in this, one dark cortical line and a central fatty marrow will be bright. And if the tumor will never be bright, tumor always have an intermediate signal. So if the tumor is going into that bright area, see the signal is slightly dark, it suggests that there is involvement. And after contrast, you can see here there is infiltration. It's very clearly seen. If the patient is very cooperative, you can get very good images on MRI, which is a problem solving tool for cartilage invasion. And this is involvement, this extralaryngeal extension through the membrane. All best seen on CT. Only for the cartilage, any suspicion for cartilage invasion only, we go for MRI. Dr. Arun.
Shall I move to Dr. Arun?
Yeah.
Yes, please.
Madam, there is one question. Actually, what about prevertebral muscle involvement? Which is better, CT or the prevertebral fascia involvement or prevertebral muscle involvement? Somebody has asked a question regarding that.
Prevertebral muscle involvement, MR is a good modality because that fat is very nicely seen. There is a fat plate just anterior to the muscle, and once that fat plate is obliterated, we can be sure that it is involving the muscle. But the thing is, most of these people will be dyspneic, they won't be able to lie down. So we always resort to CT only. The CT gives some idea regarding it. But accurate delineation, if you want, you have to go for MRI. Because muscle has a different texture, the fat is a different signal. So this tumor has a different signal. If the tumor is going into the muscle, it will be nicely seen.
What about, ma'am, base of tongue involvement? Which will be better, CT or MRI? Base of tongue.
Base of tongue, for tongue, MR is better.
Okay. Okay. I would acknowledge the presence of Dr. Renu Jolly, Dr. Rajesh Raju George, Dr. Kanagarajan, Dr. Manoj Ji, and Dr. Hemalata to be involved in this webinar. We also welcome Dr. Sajid Babu from Malabar Cancer Center. We welcome you to this webinar, sir.
Thank you.
Right. So,
Dr. Sajid is here.
hi, Sajid. Hello.
Hello, sir. Actually, I was at the Tata master course and
yeah, it's going on. I am aware of that.
so
Yeah.
that's why I joined later because I thought this also needs. I missed
No,
out
no.
the previous ones. As Arun sir was saying, CT scan and imaging is one of the most important thing to decide upon larynx treatment. Now we also have a always a question when we deal with early cancers. Okay, for advanced laryngeal cancers, yes, we need to know whether it is T4 or whether we have to go for organ preservation or surgery. But even in early looking tumors, in early T1 looking tumors, we might decide upon doing a laser surgery. And again, in those patients also, we need to have an imaging, because sometimes what we see through endoscope may be little, which may mask the real picture. So
Right,
actually, if somebody can see whether actually do we have an answer to that in early glottic cancers, which modality is better?
And there is also this issue that supraglottic tumors, piriform fossa tumors, even though they are small, they have small primaries, they can throw up significant nodes in the neck which would upstage them. So again, I take your point that don't go by the looks. Small larynx, small hypopharynx, CT scan should be one of the investigation of choice in these, right?
Correct. And
Right.
Usually what we would see, because we are in a referring center, sometimes many people, most of the time, the moment it is diagnosed, CT is the next choice. But we often look at the packs and computer. Through the computer, we see the finer points, and
Correct.
that we miss whenever we get a CT from outside. So whenever somebody is referring, it has to be with the CD, and that has to be a must now. Because now I think reading it through the computer is very easy, because we need to see the finer points. We have to look at it ourselves and see where exactly are the tumors, because we may not usually depend on the report alone. Do you agree,
Right.
Dr.?
Oh yeah, perfectly. No question about that. So come with the images. Usually we refer them back to the place where they had it and get all the DICOM images on a CD, and we put it into our server. And more than that, you may sometimes see it on your own screen. I would prefer to see it on the larger screen, the high resolution screen that they have in their radiology department. And you would be surprised that many of things which you missed just pop out when you see them on a larger screen. Have you seen that? Yeah, yeah. Thank you for putting that across. It's a great message. Though, when you're sending a patient for treatment, please make sure that you collect the CDs, and similarly, slides, just not the pathology report. They would want the slides with them, and our pathologists would want to have a look at those. Right?
Right.
Okay, sir.
Thank you, Sajid, for your inputs. That was great. So, just to recap, so no question about it. This is a cartilage invasion eroding the anterior lamina of the thyroid cartilage, going into the soft tissue here, and this has an extralaryngeal spread. So again, just to refresh you, the three things that we need to decide on whether the patient would go for a surgery in terms of a laryngectomy or a laryngectomy with a neck dissection would be a cartilage erosion, an extralaryngeal spread. But there is another entity which is coming up slowly. Since we have had so many years of experience with preserving larynges, now we know that a preserved larynx need not be a functional larynx. The organ may be in place, but it may be a dysfunctional organ, meaning the patient would still have a tracheostomy tube. He may still go around with an nasogastric tube. His quality would have been much better if he had at least taken out his larynx and given him adjuvant treatment. And so that is where another modality of radiology comes to help. And this is usually does with us, with the surgeons and with our swallowing therapist in our presence. And it's a thin barium study. It's a video fluoroscopy that you do. And this is one of those tumors which does not typically qualify for as a T4. There is no cartilage erosion, but a voluminous large larynx patient comes with a tracheostomy done at some other center, and you see some pooling of saliva in the piriform fossa. And when you suspect that the patient has some cough, a chronic cough, he's aspirating, and these patients need to be excluded from chemoradiation protocol. Probably surgery would have been a better. So just to view that, this is the thin barium which goes in. You see the tumor bulk here. So the epiglottis popping up, and you see the staining of the trachea as it goes down. So that is bad. That is bad. If that happens, if there is aspiration, it's a dysfunctional larynx. Patient is already on a tracheostomy tube. he would not go for chemoradiation protocol. So again, huge, decision making is entirely based on radiology, either by CT or an MRI to augment it. And where you find the local extent, you find cartilage erosion, you follow it up with a video fluoroscopy. All the patients don't undergo fluoroscopy as a routine. They do a flexible endoscopy, and you would have a clue as to who is having some kind of a silent or a minimal aspiration, or maybe sometimes even an overt aspiration. They would go for a video fluoroscopy, and only when they pass this test would they go in for any organ preservation protocols. Otherwise, it would be up to the surgeon to take him in his charge. Neck nodes, again, in general practice, isn't this a very common issue? People of all ages, sex, whatever gender they have, do come with. And the first question you ask yourself, is it malignant? Cancer or no? Right? And you have a look, you scope the patient, and you can't find your primary. And now we know, so over the years, the pattern by which these unknown primaries come from have changed. Abhilash, okay? Audible?
Okay. Okay.
Okay, right. So it used to be the nasopharynx at times, but since optics have evolved, most smaller clinics have endoscopes at this point of at least a 0-degree nasal telescope. We are picking up more and more nasopharynx, but tonsil remains a mystery. This cancer develop somewhere deep in its crypts. It looks slightly hypertrophied, then everybody has asymmetric tonsils if you look carefully. Base tongue, another difficult area, maybe because you're pulling on the tongue, the patient needs to be cooperative to get a good view of that. So things are now moving from the nasopharynx more towards the tonsil and the base of. So Dr. Sandhya will tell us how do we find out a primary. Now, is it important to find a primary? It's important because treatment would vary. An oral cancer, if it's a primary, it would be surgery, but it's a nasopharynx, larynx, the field of radiation would change. Many centers would, it's called a wide field radiation, because you don't know the primary. You have to complete like putting an atom bomb into these patients when they treat them with the radiotherapy. It's also important that your pathologist pitches into this whole equation here. And if it's a squamous pathology, it must be somewhere from the aerodigestive tract. If non-squamous, then probably it's a thyroid malignancy, or maybe sometimes even a parotid, or you may be having somewhere an infraclavicular primary, most often lung and maybe even abdominal malignancies sort of present themselves as nodes in the neck. So again, since nodes are an important, and nodes have been covered with many of the other primary sites that we have discussed, like the salivary glands and thyroid, I thought I would focus on unknown primary. And this is something, usually you would send for an FNAC, and the pathologist will tell you, there is malignancy in there. And then immediately you would send them to RCC or to Dr. Sajid to find out where the primary is. I think that is when we seek upon radiology to help us to find where this primary is. And another issue with nodes is that many a times they come with large nodes. Dr. Sajid, don't they? N3 nodes, large nodes. And since these nodes lie around the carotid sheath, this is something we dread, is carotid invasion. If it is invaded and you leave tumor on the carotid, probably you have not achieved much with your surgery. So 2 issues with lymph nodes, Dr. Sandhya. What is the best investigation to detect an unknown primary? How will you let us know where the primary is? What is the best way to go ahead with it? And the second thing, I would come to you and sit on your console and ask you, is it stuck to the carotid? Many a times the answers are given only when you try to put in your mosquito, your dissecting forceps around and try to get it out. But the radiologist will give you a clue at times. And we'll hear Dr. Sandhya, how do we approach these 2 issues? Over to you, Dr. Sandhya.
Can you take a question by the meanwhile when Dr. Arun?
Yeah, of course. You can do that. Whenever we are switching, there is a lag, so you can take in that break, Abhilash.
You are muted, I think. Can't hear you.
Sorry, Abhilash, you're muted. Abhilash, you're muted.
Yeah. In case of a T3 glottis with paraglottic spread with no neck nodes, should we still go for CTRT? Patient is on a tracheostomy tube, so T3 CA glottis with paraglottic spread, no neck nodes. Whether we
Yeah,
should
so
go for
that they go for, you asking me that question?
Yes, sir.
Yeah, they
Yes.
would go for chemoradiation, right? There is a, we have hold those 9-1-11 trials. They have been reported more than a decade ago, which compared 3 modalities for advanced laryngeal cancer, which is basically includes the population which was just mentioned, staged as T3 or T4, right? Stage 3 or stage 4 cancers, where they were put in 3 arms. One group got NACT, which is neoadjuvant, meaning they got chemotherapy before and radiation later. One group got radiotherapy alone, and another group got chemoradiation, and that too concurrent, because there are 2 groups getting chemoradiation. One is getting as an adjuvant, meaning chemotherapy first and radiation later. Another group getting chemotherapy and radiation together simultaneously. And we found that the group which is getting CTRT or chemoradiation showed better survival and better larynx preservation was better. So the protocol worldwide would be, following protocol would be to give chemoradiation even in the absence of neck nodes.
Okay. There was one more question by Dr. Hemalata, whether to go in a small setup, basically in small setups, whether to go for biopsy and refer with tissue diagnosis to a higher center, or refer as early as possible with a clinical suspicion.
I would say that please don't go for an open biopsy. The issues with open biopsies are, one would be you are creating an incision which may not be in the same place as a neck dissection. Maybe sometimes in larger neck nodes, we would have to do a neck dissection, and you would violate the field, the planes would be lost, and a subsequent surgery would become difficult. Why do you want an excision biopsy? I think pathology nowadays has progressed so well. There is so much of a volume of experience with FNACs. So probably I would sort of decry that the practice of getting an open biopsy. Please go for a FNAC. If you need architecture, sometimes lymphomas need architecture. Is one area where you may go in for a biopsy, but that you do not know when you see them initially. I would still prefer that you do an FNAC, or maybe even go for a core biopsy. There's a technique called a core biopsy, where a core gun would sort of take a slice out of the lymph node. That is good enough to give you a diagnosis. So please don't put incisions, because they impair with placing incisions later when you go for definitive surgery. And there is a theoretical risk of dissemination of the disease if you don't take out the node completely in its capsule. And the extent of surgery would be more difficult for the surgeon who is treating these patients eventually.
Whether she was also like to know whether we should wait for the FNAC result, or should, with the clinical suspicion only, we can refer to a higher center.
Please don't send them with a clinical suspicion, because you may be treating with tuberculosis, which can be treated with your RNTCP guidelines in the nearest health center that you have. For that, the patient would have to travel all the way to RCC Trivandrum or to Malabar to meet Dr. Sajid. So get a diagnosis, at least get an imaging if you feel you need to. An ultrasound will give you a great idea about what it is. And then get an FNAC. With that, armed with that diagnosis, probably you can send them to a higher center.
Thank you, Dr. Arun. Over to Dr. Sandhya.
In an unknown primary, first of the primary. Level 1 and 2 means above the hyoid, usually the source is oral cavity, oropharynx, nasopharynx, salivary glands. In 3 and 4 means below the hyoid, it is usually from larynx, hypopharynx, thyroid, etc. So we'll get some idea from where the primary can be. Then what we follow in our hospital is we do PET-CT, then USG neck with guided FNAC, or they will go for excision biopsy, a pan endoscopy, And if you are suspecting any lesion from the oral cavity, oropharynx, nasopharynx, we prefer MRI and an ultrasound for thyroid. This is the protocol we follow. The operability of this thing. We routinely do CT scan to see for the carotid encasement. If it is less than 180 degree, even then it is difficult to say when the tumor is closely adherent, very close to the carotid artery with no definite fat plane. The chances of encasement are still there. If it is more than 270 degree, it is definite there is encasement. And slight deformation and that obliteration of fat between the node and the carotid artery all is suspicious of invasion of the carotid, which can be seen in a evaluated with a CT scan. I think that will be that protocol what we follow here. Somebody was asking about the prevertebral muscles. Here you can see there is a nice fat. This is a dark, white, bright area. That is the fat anterior to the prevertebral muscle. If that is obliterated, it is a sign the tumor has gone into the prevertebral muscles. Arun? This is the protocol what we follow. PET CT, panendoscopy, MRI
so
for
over to Dr. Arun.
Okay, Dr.
Please activate my share button, please. I would.
We acknowledge the presence of Dr. Sanjay, the eminent radiologist from Pune. Very welcome, Dr. Sanjay Ved.
Is Dr. Arun?
Yes, sir.
Hi, Dr. Sanjay. Hi. Really enjoyed the last two sessions that we had with you.
You're on, sir.
Oh. Okay, can I move on?
Yes, sir.
Okay, right. So again, like Dr. Sandhya said, a PET would be an investigation of choice in an unknown primary. So not only, so many a times, but when you read PETs, there's a lot of caveats and caution associated with that. Please remember that PET is not an imaging for cancer. It's a metabolic imaging. And many a times lymph nodes, sort of areas of primary may take up even in inflammation. If there is an abscess, if there is tuberculosis, we see more here in Bengal than you do in Kerala probably. But the back of your mind, you're always worried, is it not cancer? The advantage of doing a PET is there have been studies by a large group, including from Europe, which have said that in about 30% of the time, there is a change in management when you do a PET. So it's something 1/3 of the patients, in 1/3 of the patients, you would change your treatment based on a PET decision. So maybe it may pick up some primary or it may reveal more in terms of the disease. And so that is why PET has now come to stay as the primary investigation modality in case of an unknown primary. And again, the PET would cover everything from your skull base all the way down to your mid-thigh. And so a wonderful tool to pick up malignancies even lower down, and even to assess metastasis in many situations. In patients, we now use it as a primary modality for patients who have bulky nodes, large nodes, level 4 nodes, lower level nodes, rather than, I think CT thorax would have been sufficient, but we're doing a PET scan in patients who could afford a PET. So again, it is important that that I've already spoken. Thank you so much. So another issue that is always a source of concern is when you get tumors like that, and that is the carotid artery out there, and a tumor sitting on the carotid. And we are always worried that, abandoning a surgery after taking up, it's not always good. And as Dr. Sandhya said, less than 180, don't worry. And again, let us remember here that it is not the size which matters. Maybe it's the biology of the disease which is also important. It may be a small abutment, but that would be something which is invading into the capsule and difficult to separate from the carotid, it would be a disaster. But radiology can guide you most of the time. The biggest issue comes when it is somewhere between 180 to say 270 degrees. But as Dr. Sandhya said, if it's something moving beyond 270 degrees, we would be very, very hesitant to go in. But anything between 180 and 270, we would look at the primary characteristics, we would look at the pathology of the disease, the histopathology, and then go in. So 270, remember the 270 rule, more than 270 of area, this would probably go in. It's about a little more than 180, but more than 270 is you would back out from these. So now move on to oral cavity. I'll tell you, we had very little experience with malignancies of the tongue when we were students in Kozhikode, because most of these went for radiation. It was not operated, even though the primary modality of treatment for oral cancer is surgery. For early tongues, where the treatment would be surgery, and if you can feel the tumor with your finger all around, it's 2 centimeters or less, I don't prefer any modality of radiology. There are some people say, hey, even tongues can give rise to neck nodes. Don't worry. Standard neck dissection has become a standard modality of treatment, even for the early tongue. We have had studies from Dr. De Cruz in Tata, Mumbai, which says that if you do a prophylactic neck dissection, so do a neck dissection, node or no node, survival is definitely better. So for an early tongue with a T1N0, many of you would go for an ultrasound to find out if that is, maybe it keeps you a little prepared. It tells you that it's a T3 tumor. If the node is positive, he will need adjuvant treatment later. But apart from that, it gives you no further information. So for early tongues, we don't. But for more advanced, something more than 2 centimeters, again, the three issues with tongue. See, tongue, it's such a fine-tuned organ, so many muscles, playing in tandem, it's source of your voice, your swallowing. It's an amazing organ, and it's your goal to save as much as tongue as possible. Just take adequate, and with an oncologically safe margin. But one of the bigger issues that we have for larger advanced tongue is it operable? Going into the vallecula, involvement of the hyoid would make these tumors technically inoperable. Going to vallecula would mean you have to combine a laryngectomy along with it. It's a very morbid operation. Hyoid involvement, getting it out, the support to the larynx is completely lost when you do that. So we would usually back out if it is going to the hyoid. Again, adequacy of your resection, going into the floor of the mouth, climbing onto the gingiva, you may have to take a margin of bone because as we said, Dr. Sajit would agree, margins are sacred for us. We need to get wide margins. Whether it is, you have to take a part of your mandible, do so. And again, approach. Yes, so many ways you would approach a tongue. Do you want to go through your mouth? Do you want to drop down the tongue into the neck and then do the surgery? Mandibulotomy used to be popular at one time, but now we realize we're going mostly for drop downs nowadays rather than mandibulotomy. But then the long and short of it that radiology will help you for the approach as well. And moreover, you can plan out your reconstruction on these images. You will find out the volume of the tongue which goes out. And you can discuss this with your plastic surgeon. You can sit around with them and tell them, hey, this is how much it's going, on 3 dimensions. And he can immediately think, okay, let's get a lateral arm ready, or let's get a radial forearm ready, or we want to go in for a fibula in this case, or we will go for anterolateral thigh flap in this case, or maybe if you need a larger bulk for a rectus abdominis flap. So many decision-making issues with the tongue when they become advanced. For an early one, probably very easy. These are the kinds you can do in your clinic. For a T1N0, no radiology, go ahead, get a wide excision, do a neck dissection, you are done. So again, Dr. Sandhya, I think somebody raised this issue with reference to the larynx. Is it going to the base tongue? Tell us, how do we assess the tongue? You must, please let me know. I just want to know, where is it? How big is it? Where is it going? Is it operable? Over to Dr. Sandhya.
Hello, ma'am.
Yeah.
There's one question. Can I ask you from Dr. Ragesh?
Yeah.
What about the human papillomavirus infection? Any specific radiological signs that you will see in
tonsillar malignancy connected with human papilloma virus? Anything specific to look for radiology?
For HPV virus, the nodes seem to be more necrotic. I don't know exactly the tonsils.
Hello,
Doctor,
Dr. Arun.
ask
Yeah, yeah,
can
very, very,
answer.
very. Yeah, yeah. So HPV. So traditionally, we used to say that smoking, tobacco use is probably the biggest risk factor for head and neck malignancies. So now HPV, or the human papilloma virus, the usual subtypes are the 16 and the 18, which again are the commonest ones for carcinoma cervix, have now been implicated in malignancy of the oropharynx. May not in the anterior tongue, but mostly in the base tongue and in the tonsils. Now the issue what we are seeing that these are not as common in India as they are in the West. And usually in a Western population, a predominantly Black population in the West, this is an issue to contend with. Most of their cancers, oropharyngeal cancers, are HPV related. Not so in India. But again, do they have different characteristics? Of course they do. Radiologically, they are large, bulky nodules. They look ominous when you look on the scans. There's a lot of cystic component in them. In pathology, they show something called desmoplasia, but they are good ones. You treat them and they respond wonderfully. Even their outcomes are better than the oropharyngeal tumors which are caused by smoking. So there are now questions being raised. Can we de-escalate treatments in HPV? So we have not reached there yet. We still continue to give them standard treatment, but back of your head, you feel a little happy when you go home and say that, oh, this guy is going to do good because he has an HPV related tumor. So HPV is definitely coming up as it has come up as an etiology for oropharyngeal cancers. Unfortunately, this subset is quite rare in India, and they do have distinct radiologic and pathologic appearances.
Same.
And it is part of our test. Yeah, it's part of our testing now. We test P16, which is a surrogate for HPV infection. And the new AJCC system, also the staging system, has distinguished between HPV positive and negative tumors. Dr. Sajid?
Anybody reading textbook or literature would surely have this question in mind, whether it is HPV, but we don't usually see them. I think all the studies in India have shown less than 20% of HPV positive,
Absolutely.
even in oropharynx tumors.
Correct.
Whereas in Western literature, it is up to 85 to 95%. So we don't see that. We don't know the reason. Maybe the sexual practice is different, or some other reason. We do not know. But as of now, we don't want to be behind the run. That is why we also do P16 in all these patients and have not found much use. But still we are doing. Second point, it is like reading MEN. I always used to think, the moment you start reading on medullary carcinoma, the next question is on MEN. Have we ever seen MEN syndromes? We don't see much, but everything is on MEN. You have to roll out and then that goes. So something like that, I always used to feel it's overhyped in India. Maybe we may find some answer later on, but as of now, oropharynx is not much of different thing as compared. Abhilash was asking any different in imaging. I think probably only nodes would be more cystic sometimes. Other than that, the primary, etc., it may not tell us much.
Correct.
Thank you, sir. Thank you, Sajid sir. Thank you, Arun sir. Over to Dr. Sandhya.
For the tongue, MRI is the modality of choice. Some institutions may be using CT, but we use MRI because it gives a better contrast resolution. And as Dr. Arun said, for T1, we do a USG neck just to characterize the nodes, but no imaging for the primary site. In advanced cases, we do MRI to assess the extent of the lesion and the nodal involvement. And, I'll just show you the difference. See, this is a sagittal view of tongue in the MRI and in CT. Here we can very accurately delineate all the muscles, intrinsic muscles, extrinsic muscles, genioglossus, geniohyoid. That anatomy is very nicely brought out in MRI than CT. But the problem with this MRI is it needs a long time to do, and the patient has to be very cooperative. You should not do it in between. So it requires a lot of instructions to the patient. After every sequence, we have to allow the patient to swallow. To get a good quality image is very difficult. But we prefer to do MRI in all tongue lesions. And this is a coronal image where you can see very nicely all the muscles are very separately seen. This is a mylohyoid sling, and this is a hyoglossus, and this is the genioglossus, and this is the sublingual space, and this is the dorsum of the tongue, and here you have the digastric muscles, and the anatomy is very nicely seen in a MRI than in a CT. And nearly all the tumors, what we have seen is seen on the lateral border or on the undersurface like this. Either it is on one border or it is going down into the sublingual space, or it may be going down into the floor of mouth. All these things are very nicely seen in MRI. You can see here, this is one case where the entire tongue is involved. And this is the base tongue, where it is seen protruding into and this is the epiglottis. See, the lesion has involved the floor of mouth, geniohyoid, mylohyoid, and is reaching up to the mandible, and posteriorly it is engulfed the hyoid. And here you huge tumor which has gone down into the floor of mouth. This anatomy is very nicely seen on MR as compared to CT, and very rarely only we have seen going into the bones, the tongue. It's enough. This is a Dr. Arun, this is enough, or whether I
Yeah, maybe, yeah. Well, I'll pick up from there. Abhilash, can I have my share?
Yes, sir. Yes, sir. Over to Dr. Sanjay.
Right. So again, we got the answer from Dr. Sandhya. Usually we would go for radiology. I think the connoisseurs may differ, but for clinicians like us, if you have to image soft tissue, go for an MRI. And the same oral cavity, if you are going to image for a gingivobuccal sulcus, probably CT would be a better modality. So for soft tissue, defining margins, extend. The only issue is sometimes you have to use the why is MRI is not very clinician friendly. It's mainly because there are so many protocols and so many different ways they could image. The images look all so different that you find it very difficult. And the best way is to again, desperately seek Sandhya to find out answers to that. But MRI remains the modality of choice for the tongue. Again, just look at that. This is an early tongue. I'm putting my finger around. And if I can feel it all through, the mouth opening is good. All that I would do is it's just a wide excision. Probably in this case, I would never have gone for any imaging. And that is completed, and I am closing up the tongue defect. The patient would later undergo a neck dissection along with the same procedure at the same sitting. Here again, when you see this image, just clicks at the back of my head. If you just take it out, maybe it's going to the floor of the mouth. You can't feel much here. And avoid just an excision and closure would leave the patient disabled. The tongue volume would be lost. And when that is lost, probably speech, some modalities of swallowing would be affected in these. And here we would go for some kind of a reconstruction. And in this case, you see what you call as a lateral arm flap. And this lateral arm flap is anastomosis, and the bulk of the tongue is restored. These are just vicryl stitches giving as the 7th or the 8th day. And again, gives you an idea. The imaging would give you an idea how much volume is going, and then you can probably plan your reconstruction according to that. And this is a larger one. This is like a total tongue. If you look at it, there's only tongue which is left. It's a small sliver here. You can see the epiglottis, the uvula here. It's an edentulous mandible. The whole thing has been dropped down. And here we use a larger paddle of skin. This is an anterolateral thigh flap, which is pedicle. and that is his reconstructed tongue at the end of the procedure. Wider still, if you think it's going to the floor of the mouth, this was creeping up the gingiva here, and we did what is called like a marginal mandibulectomy. The lower rim is restored here, but it's almost the entire tongue coming out with a margin of mandible. More advanced tongue, you will have to plan some kind. This is going into the mandible, ascending ramus, and the arch here, like an L segment of the mandible, has gone along with that. See the endotracheal tube in there. You can see the epiglottis. This is the chin of the patient. This is a cheek flap which has been raised. So the mandibulectomy, along with a total tongue, has been done in this patient. I know what you're thinking. So that is when again you would go back to the radiologist. Many a times, our swallowing therapist, this cannot be done in a single one-man show. Requires a lot of dedication, mainly from a swallowing therapist who would persist with that patient. You would find that the base tongue is intact, but there is a slope here which would sort of, with a little bit of gravity, you can take the foot down, and I'll show you how it goes. And the patient has a you can see this black line moving. That's the nasogastric tube, and this has been done to find out whether you can remove the nasogastric tube in this patient. And so there he goes. The base tongue is working, but you see there is no mobility here. It's just the base tongue pumping up, and his jaws are moving up and down to force that fluid posteriorly. It's just a physical action. There is no muscle here in the tongue. But you see it's like going down here. This is the trachea here, and there is no aspiration. So in this patient, we are going to take out the nasogastric tube as well. So he's going to be decannulated of his tracheostomy. We are going to take a nasogastric tube as well. So you need radiology in order to follow up these patients after these supposedly so-called morbid surgeries. So that is it again, right? So we move on to another subsite in the oral cancer. Even though they are all staged similarly, they are classified similarly, subtle distinctions between whether they come. Gingivobuccal cancer is what we call the typical Indian cancer. Or as I migrated north, I found I'm seeing more of these gingivobuccal cancers. I used to see more tongues in Kerala, in Amrita when I was there. But when I came here, I'm seeing, because these people have the habit of putting what is called that gutka. I think in Kerala also, I think a lot of youngsters use that Hans. And exactly where you place this tobacco, you would find these cancers coming. And the difference between tongue is that they do not involve the skin, and tongue doesn't involve skin and bone. But gingivobuccal cancers are quick to invade the skin and bone. That would sort of, one of the key issues would be bone. How much of bone is involved, which will help the surgeon. Again, so the mandible takes center stage now in gingivobuccal cancer. And here we want to know, is it just an abutment? Is there a cortical erosion? In this case, I would go for a surgery called a marginal mandibulectomy. It's criminal to take an entire mandible just because the disease is touching the gingiva of the jaw. I would prefer something, or the standard of care would be something less than that. But if there is erosion, if there is tumor is going into the mandible, there is no way I'm going to save this mandible. This mandible has to be removed. So help me, Dr. Sandhya. I want to know here in this patient, what is the best investigation to help me decide on what I do to the mandible? Over to Dr. Sandhya.
Dr. Arun, there is a question from Dr. Vadisha Bhatt. Whether there is any difference in the management of P16 positive oropharyngeal cancer in the management of neck node?
As of today, no. As of today, no. We still continue to treat them as oropharynx based on our current staging systems, even though we know they do better. But there are, watch out, Vedisha, there are a lot of studies coming out which are called de-escalation trials. We don't have any robust ones yet, but the people are now trying to do that, decrease treatment in one arm. It has to be done carefully. It has to be done in a study setting, and the results are awaited. Once they do come, probably there is a role for decreasing treatment. But that's a huge decision which you need to take, and it should be based on studies. So as of today, you have to treat them just like any regular. And India, more, Sajid pointed out, we don't have too many HPVs in India. So beware before you de-escalate treatment in patients. Question? Okay. Thank you.
Thank you, sir. Over to Dr. Sandhya.
Yeah.
Yes, sir. Thank you, sir. Thank you.
Gross involvement infiltration can be seen on CT. I feel that CT and MR have a complementary role. MD CT is a 16 slice and more should be used for evaluating the mandible. And we will take a volume imaging and make sagittal coronal reformats. But the problem with CT is when there are subtle alveolar erosion and marrow involvement and perineural involvement, they are still difficult to pick up on CT. MRI may be needed in such cases. And MR to evaluate the bone marrow and the perineural spread, MR is a better modality than CT. Only problem with MR is it takes a long time, so the movement artifacts it is following can sometimes degrade image quality. And the contrast examination is needed in MR to characterize the marrow. The role of imaging is to assess this cortical involvement, marrow involvement, and how long, the depth and length of erosion, and what is the height of intact mandible at the site of erosion, and height of mandible which is free from paramandibular spread, and the neural invasion. So I'll show you a few pictures here. This is a CT picture. Here you can see this is the height of the paramandibular spread. This is a CT.
Madam.
Yes,
ma'am. Yes, ma'am. It's clear now.
This
There
is
is a lag. It's clear. It's clear now. Yeah, it's clear now.
It's a puff cheek method in which you can see the cheek is separated from the mandible. So the bony alveolus is seen separate and the cheek is seen separate. This is a normal cheek. On this side, you can see irregular thickening which is reached up to the mandible. So this is a coronal image which gives an idea of how far the lesion is in contact with the mandible. And this is also important that what is the height of the mandible which is free of disease to evaluate for the marginal mandibulectomy. And the subtle erosions, you can see this. This is also, this can be appreciated on CT, but very subtle erosion and the marrow involvement, that can be best seen on MR. In MR, this is a post-contrast image and this is a plain T1. The cortex will be dark in color and the central marrow will be white. This is a T1 weighted image. You can see the central white, the normal marrow. And here, this area, that marrow signal is lost. It is dark. And on contrast, it is enhancing. This is suggestive of marrow invasion. This will not be because the cortical line is intact. If that is eroded, we might see on CT. And this is another case where that cortical dark line is lost, the CA which has infiltrated into the mandible. And here also we can see that the cortex is eroded and the central white signal of the marrow. I feel CT and MR are complementary. If you see a gross erosion in CT, you can stop with that. An MRI is needed to evaluate for the marrow. Dr. Arun.
Thank you, ma'am. Arun sir, for the sake of postgraduates, can you just tell us about the prerequisites for a marginal mandibular?
Oh, yeah. Come. I'm coming to that. Just a minute. I'll just take you through some pictures to tell you that, right?
Yes.
So that is it. Look at one of the prerequisites for a marginal here. This tumor is sitting on the mandible, right? And this does not qualify immediately for a segmental mandible. Okay? You won't do a segment. You have to go for an imaging to find out. And here is this tumor sitting there. And one of the best ways of telling it, Dr. Sandhya would agree, is to do what is called a window. You window it for the bone. This is a bone algorithm which would sort of tell you that there is no invasion, but there could be a mild cortical erosion. One indication is that a tumor sitting on the mandible, not involving it, there can be a cortical erosion, but it still is a candidate for a marginal mandible. See, a mandible is a wonderful structure. It gives structure to your face. It supports so many muscles which, help you in your speaking and swallowing. It cannot be taken out willy-nilly. You have to preserve the mandible where you can if it is oncologically safe, and these are one of the areas. The second thing which I would want to emphasize would be to look at what is called paramandibular invasion, which Dr. Sandhya just mentioned, because you need to save rim of mandible here. You need at least a centimeter. You see the coronoid process has been taken off, and this is a rim of mandible. There should be no paramandibular spread, meaning you should be able to get a centimeter of bone. If you can't get that, there's a high chance that it would fracture eventually. And many of these patients would go for radiotherapy, and they would develop an osteoradionecrosis because making it thinner and smaller would compromise on its vascularity as well. And so beware, you cannot thin out the mandible too much. The third contraindication is don't do marginal mandibulectomy in a radiated patient. Again, the vascularity is compromised, and so you would not do it. So marginal can be considered if it is just sitting on the mandible. There is no gross erosion. There is no paramandibular spread, and the patient has not received radiotherapy. In such situations, you can very well save the lower border and retain the structure of your face. Advantage of doing a marginal mandibulectomy. Here you see that we have put in a flap. This is probably a local flap. I would have used an infrahyoid here or a submale, so infrahyoid flap here. Now this used to be our practice initially. Nowadays we are putting in more skin grafts because it gives a basis. The skin graft sticks to the bone, and it's a hard base onto which you can place a prosthesis. In order to place a prosthesis, how will things sit on something which is jiggly? The base is not, it's moving. So no structure can stand on a jiggly base. So you will have to thin out this flap later, called a pre-prosthetic surgery, before you can place that. So in this patient, it's a bone is well healed, the graft is sitting in place, and this has a strong foundation on which you can prosthesis. More recently, we have an implantologist in our team, Asif Ahmed. Asif is our implantologist. He would now assess these patients to put in implants into the marginal. And he just stands behind me during my surgery and say, hey, sir, I need a little bit of rim around that. And I fight with him and say, no, oncologically, I have to be safe. I have to get my margin. So don't play to your implantologist. He would want a thicker base. You take your margin. If you think you can't take your margin, do a segmental rather than make space for your implant. So now get an prosthesis here over the flap. He has a radial forearm flap, which you cannot see in this reconstructed image. Again, if there is bone is involved, you think that the marginal will not be adequate, go for a segmental, but please do reconstruct. Here we see, this is one of my older picture. We don't use these heavy recon plates anymore, but this is a fibula flap, and this would form the skin lining of the oral cavity. So that is all about. Any questions, or I'll move on to the next topic, maxilla.
So regarding the use of pre-planning with 3D reconstruction for these defects, like you can plan 3D reconstructing the defects.
Yes, Abhilash, there are a lot of techniques available. So one of the biggest issue is to replicate the mandible from the opposite side. Unless your reconstruction is symmetrical, it loses its cosmetic charm. A 3D recon will give you, and more importantly, we do it if we want to get, you can have a 3D model created. More than an image, we would create a 3D model. And these 3D models, you can do it as a flip model, meaning you can just flip the left to the right and use the normal side as a template for the affected side. You can actually contour these plates before surgery on the opposite side. Put the teeth, you see these arch bars there? You can put the teeth back into occlusion, and you can put the bone into this framework. So that is where 3D imaging is. Many a times, we can plate this on the lower border of the mandible. If the tumor is somewhere high, you can expose the lower border from the neck, and you can plate it from the lower border. But if it is a large tumor, you cannot use the lower. The lower border is also, you see it in ameloblastomas mainly. You cannot do it. In those situations, we go and plan it on the opposite side and bring it over to the ipsilateral side.
So that's what. So in cases where there are through and through mandible defects and then the whole area is replaced and then bulky, we may not be able to plan. So what we usually like this, as we see it in the picture, those kind of defects are the ones which we do 3D planning. So it's pretty simple. We do the planning in the preoperative, with the preoperative scan. Virtual planning is done, and we exactly get how much of length of fibula has to be taken, how much angle it has to be taken, and then how many segments of fibula has to be broken. So that makes it very easy, because otherwise on table we will have to keep adjusting, trying to do whether this shape is okay or not. So that process becomes much more easy with preoperative planning. And ameloblastoma, we have no experience, but I've heard that they do the flipping and then do that.
Right, sir.
Right. Thank you, Dr. Sajid. I think even the osteotomies can be shaped accordingly in the 3D model.
We can have guides for osteotomy also.
Yeah.
But that needs, we don't do that much. We used to do, but it needs much more precise things. But we adjust with our.
Thank you, sir. Sir, Arun, sir.
Right. So we move on to the maxilla. And if you had followed the first series of lectures where Dr. Sanjay Ved took us through the anatomy for the endoscopic surgeon, I think more or less the principles of imaging the maxilla remains the same. What really matters for people practicing out there is to differentiate it from a malignancy. Tell me if it is cancer. If it is cancer, your debulking is not going to help me in any way. You may have done a FES, but if you have not gone around the tumor and got a margin, wherever in the body it is, there is no way of salvaging it with chemotherapy and radiation later. So before you put in your endoscope and before you start plucking out tissue, please remember now, I hope this is not a malignancy. If it's a malignancy, what you are doing is a grand biopsy. Why don't you just send in a few bits of tumor, get a diagnosis, and send it to the nearest surgeon? If you see there is gross bone erosion is going into the infratemporal fossa, you are dealing with more than what you can chew, and your debulking has not helped us in any way. But in terms of imaging, sometimes when you look at a CT scan, you get a jolt and you say, oh my, this tumor is going everywhere. And then I rush to Saugata, send my radiologist, and Saugata sits there and let us look at the MRI. And look and behold, most of what I saw would have been retained secretions, inspissated secretion. He would run through the MRI and show me the various sequences, say, hey, no, don't worry, this is not breaching the skull base as you thought. So in maxilla, this is important to know. How much is tumor? How much is secretion? How much is those dried, inspissated mucus there? So defining tumor is one of the bigger issues. Moreover, by defining tumor, it makes these areas lie hugging the skull base, and you may have to call in your neurosurgeon. They are difficult people. It's very difficult to find, very busy people. So you have to plan your surgery, and slots in Tata is so difficult. You can't say that, I book an 8-hour slot and I'm done in 1 hour. No, or you book for 1 hour and the surgery goes for 10 hours. You have to plan. And that's where I think it's the same in most centers anywhere in the world. So it is important to tell me where the tumor is. Is it going into breaching the dura? It's going into the brain. Is it just abutting that? That is the eye is another issue. Most of our patients with advanced maxillary cancer refuse surgery when you confront them with the issue of taking out their eye. Most people say, no, chhod dijiye. Don't take out my eye. So orbit, can I preserve the orbit is another question that sort of hangs in my mind every time I see these maxillary tumors. Again, just like the larynx, a preserved organ, if it's not a functional organ, you have lost the game. And the orbital floor is a key area that supports. Most of the time patient ends with an anaphthálmos, a diplopia. I have lost the game. It's a useless eye. I would cover it with a black patch and say, you just see with your one eye, that's better. Skull base, as I told you, they are very high sort of predisposition to grow, and intracranial, if it involves the brain, outcomes are usually bad. Dural, extradural, yes, I would be more inclined to go in. So, lot of issues with maxilla, Dr. Sandhya. Number one, how do you know where the tumor is? Number two, can you let me know whether I can save the orbit or the floor of the orbit for that matter? It would also sort of alert my reconstructive surgeon that we need to work on the orbital floor. We need to reconstruct it. Intracranial extension, skull base involvement. Again, I may need my neurosurgeon. Otherwise, many a times we combine endoscopic surgery with open in these situations. But if it has to go into the cranial cavity, go beyond the dura, then definitely I would call in my neurosurgeon. And what is the best imaging? How will you help me? Over to Dr. Sandhya.
Yes, ma'am. Your screen is visible.
We mainly do MR, but a CT is indicated when there is when to know more of the bony anatomy when it is involving the skull base. I feel both CT and MR are complementary. The role is to differentiate the tumors from the secretions. MR is needed because the secretions are very bright on T2 and the tumor tend to have a dark signal or an intermediate signal on T2, and the secretions will not enhance on after contrast and the tumor will enhance. So any pooled secretions we can make out. For that MR is necessary. And in MR itself we can see the bony margins, erosions, and involvement of the orbit is also very nicely seen. Here you can see it is going into the extra corneal space, abutting the muscles, and it's eroding and going into the cavernous sinus. And involvement of the dura and the skull base can be seen separately. Dura is seen as a dark line. It will be lifted up. And if it is involving the brain, neuroparenchyma, there will be edema in the parenchyma. All this are nicely seen on MR than CT. But still that anatomy of the skull base is very complex. To look for the foraminas and all, I would always like to have a CT and MR together. Dr. Arun?
Okay, thank you. May I take over?
Yeah.
Yes, sir.
Thank you, Dr. Sandhya, for passing that excellent message. You know, this is a difficult area to treat. This is a difficult area to image, and maybe one modality of treatment may not be adequate for the maxilla. There's so much information about the bone, about the skull base, which you get from a CT, but to characterize the tumor or sort of delineate the tumor, maybe MRI is a good idea. So for maxillae, we have a separate protocol. You just have to order a maxilla protocol, and the CT gets done immediately with the maxilla. So that is what we do. So take you through a few clinical examples. So I just wanted to show you all in one kind of a tumor. So here you know that's a maxillary tumor. There is proptosis, very evident. There is a bit of chemosis here. So this patient has a very destructive lesion of the mandible. Now this won't go for FES, I am sure, in your book. You see that the bone has been destroyed, and this is a CT scan, but where is the tumor? It's better delineated on an MRI. You find that the lateral pterygoid muscle is involved here. It's a maxilla. Other cuts would say that it has even come close to the skin. And this is going into the orbit as well. I've not taken the entire series out, but to summarize, it would be a maxillary tumor, not going intracranially, but laterally it reaches up to the zygoma and involves the bony vault of the skull and part of the temporal and the parietal bone as well. And so that would be our surgery in this case. So the whole maxilla would have to be removed, the infratemporal fossa. This is the parietal and the temporal bone. It's a huge challenge and for the reconstructive surgeon. So the face is reconstructed with a fibula. This provides not only structure to the face, but we create an oronasal separation. That would be a huge boon in terms of rehabilitating this patient, in terms of bringing in an early swallowing. And for the skull base, we prefer something like a muscle flap. A muscle would seal off a little bit of CSF, which you would usually expect in these cases. And this is a rectus abdominis with a deep inferior epigastric artery, as the pedicle would be anastomosed to the superficial temporal artery and the vein. And that would be. So the beauty of reconstruction, this is around the 7th or the 8th day, the nasogastric tubes are out, the patient is eating by mouth, and the tracheostomy tube is out, and the patient has been decannulated. We have left a depression here. We would fill that up with a prosthesis. We wanted a prosthesis which could be stuck on here with adhesive, but she preferred to have a spectacle bond prosthesis later. So that would sort of speak about the mandible. So with that, in spite, I'll end with where I began, is, desperately seeking the radial. The reason why I do that, even though you could read your radiology to some extent, always, when we are going for a major undertaking, it's a good idea to sit with your radiology. Many a times, Dr. Saugata Sen and his colleagues have shown me a perineural spread. Tumor can just creep up these nerves, especially the mandibular nerve, and go through the foramen ovale into the middle cranial fossa. Recurrent disease, since we put these big flaps, you have to be very alert to the patient's symptoms. Any small change in symptom, the patient will be the first person to tell you headache, small nagging headache. And it's very, very difficult. See, when you do surgery and a reconstruction, the poor radiologist usually relies on something called symmetry. That's a great tool to have, because the head is so symmetrical, you can compare one side with the other. You have completely demolished that symmetry. So it becomes difficult for them to find out. But they are brilliant people. They have techniques to find out small recurrences. And it's important to catch these recurrences young, because in that case, you can go back in again and do a salvage surgery at that point. I have been fooled by the cancer many a times. Just a small tumor sitting on the mental foramen area, and hey and presto, it creeps into the mandible and goes the way. And when I do a segmental mandibulectomy, the pathologist comes back with a positive margin at the cut margin. And sometimes I don't believe it. I say, hey, how come I have taken a 2 centimeter margin? How can I be close? And then I go back to my radiology and thing has extended through the mandible. So initial failures makes me wiser. Usually rush to the radiologist and make sure there are these special situations where only a radiologist trained like I can pick up what you would. Dr. Sandhya, anything about all the issues that you have covered many of them, but in closing, maybe you would want to summarize on these special situations, and then we will wrap up this session. Thank you. So over to Dr. Sandhya.
Ma'am, there is one more question from Dr. MRI. Periorbital spread. What are the earliest signs that you've seen in MRI to see for periorbital spread, periorbital involvement?
See haziness in the extracorneal fat, and the dark rim of the periorbita will be lost.
Anything with the muscles, madam? Displacement of the muscle.
The muscle, once it is involved, will be swollen, and usually it is dark in color. It will take on signal of the tumor.
Okay.
I'll give my experience. This is a classic teaching that goes around, which says that decision making for orbital exenteration is involvement of the periorbita. Very difficult to say it on MRI Vechari. It's like the facial now. Many a times you find it if you are able to separate it from the tumor. If you're able to separate it from the tumor without leaving gross disease, leave it alone. The eye is important. You won't do it. I have even tried resecting part of the periorbita, reconstructing it with the fasciolata. Tell you I'm not very happy. Patients do have diplopia. Once the periorbita is breached, and the third issue is if it does reach the periorbita, it's an extensive tumor, the patient is going to get radiation to the eye, and that will leave a painful red eye there. So rather than go and scratch around the periorbita, I would rather have a consent preoperatively and remove the eyeball at surgery. So that would be my approach to the periorbita. The answer is, the long and short of it is that even with the best modality, it's how it comes in your hand at the time of surgery.
So regarding the role of Frozen biopsy in periorbita? to spare the period?
Frozens can be sent all the time, but many a time frozen also needs a little bit of tissue to be stuck on. The periorbita is a very tough structure. It resists invasion. So many a times there is a little bit of stranding there at surgery. It may be because of the inflammation. So if you have to send frozen, you have to cut it out, right? Once it cuts out, the fat pops out. And what you try to avoid, you have already done that. So not a very good way to handle the periorbita, Vilash.
Yes, thank you.
Right?
Yes, over to sir.
So, yeah, please, over to me, please.
Over to Dr. Sandhya.
Dr. Sandhya, please.
For perineural spread, no, sir. The preferred modality, because in CT we won't be able to see the nerves, and we require a high resolution image. There are certain features by which we can differentiate it. Always this nerve is surrounded by some amount of fat, which is seen as a dark signal. In CT it is seen as a dark area. If that is obliterated, we have seen that before facing the stylomastoid foramen. That fat pad, if it is obliterated, that is one sign. Or if you see a thickened nerve and enhancement along the nerve, this thickening and enhancement can be appreciated only on MRI. That juxtaforaminal fat pad may be visualized on CT, but it will be more distinct in MRI. CT is detected only late when the foramen enlarges or when there is bony erosion. And you can detect some denervation changes in the muscles supplied by the nerve. There will be edema, and later on these muscles will go into atrophy. These also is better appreciated in MR. So one here, there is a direct involvement of the mental nerve. You can see this is a carcinoma lip in which has eroded the mandible, and this inferior alveolar nerve here is very much thickened and enhancing. It's very clear cut. It's seen on both sides. It is this way through the mental nerve. It has entered the canal here, and CT images to show you. This is a pterygopalatine fossa on the right side. This is the left side. You can see some widening, and that normal fat dark areas are not there. The fossa is widened, and you see a soft tissue thickening there. This is suspicious. Similarly, here this is a site of greater palatine foramen. Here you see some fat signal. Fat usually gives a dark signal. Here that is obliterated, and this another CT image. You can see this is a foramen rotundum, and here you see that margin. It is slightly widened, and there is attenuation. When you see the bone thickness here, that margin is attenuated. These are subtle findings of. So it is indirectly suggesting that this nerve is involved. And if you actually want to see the nerve, that will be seen on MR. Here you can see that foramen rotundum, this area, that nerve is not there. Here it is involved. That's why it's thickened and it is enhancing very nicely. This image I can't see. And here, you see here, there is another round thing. This is probably the site of greater palatine foramen. So you can actually see the nerve, the thickening and enhancement in MRI than in CT. CT, it is usually seen slightly late when the foramina widens and there is erosion. And this is one case where the mandibular nerve is involved. And you can see these muscles here, pterygoid muscles. This is a stir image that is showing bright signals due to edema. And it has become atrophic as compared to the other side. Here you can see the muscle fibers nicely. And here that due to edema, that fineness is lost. There is an alteration. You see that there is loss of symmetry. And this is an indirect evidence of nerve involvement. These are the ways by which we pick up perineural spread. Dr. Arun, please.
I think, Dr. Sandhya, if you have, I think I've come to the end of my slides, I guess. Let me just have a quick look and see whether there's something left. Okay, so perineural spread, marrow disease. Okay, no, I'm done. If anything, with that, I think we come to a, yeah, you have something more to say, Dr. Sandhya? I'll close otherwise.
Look, we're talking of post-op situation, the flap recurrence and all in tongue.
Go ahead. Maybe you can share your slides. Share some of your slides if you have.
We have few images of flap recurrence.
Sure. Go ahead, please. Please.
Okay, ma'am, we are seeing your screen.
Yeah. In tongue, when you see, usually the recurrence is a normal flap. The flap, that central area will be bright due to fat. And MRI is the modality for assessing recurrence in a post-op situation. As the time passes, what happens is the flap shrinks. And if you see usually recurrence happens in the margins, and any thickening or any alteration in the signal in the margin, and if you give contrast, there will be enhancement. And sometimes it is so subtle, it is very difficult to pick up in a conventional MR. In such cases, you'll have to go for a PET. It's a PET lighting up this thing. And there are two modalities we use, but I feel PET is more beneficial than that. That is a diffusion weighted imaging and a perfusion weighted imaging. In diffusion weighted imaging, there will be diffusion restriction in the movement of the Brownian motion of the water molecule. So that gives a high signal on MR. And in perfusion, we can see there is a rapid uptake at the site of tumor. So MRI is the modality when you are suspecting a recurrence in the post-op cases for oral cavity or tongue.
May I have my last two slides, please? I just want to wrap up. I think we have had a very long evening today. It's 2.5 hours. And if you are not physically tired, certainly, I think it's time for rest. So it's my duty to thank all of you, everyone from Kottakkal, from AOI, Malappuram, Prabharan sir, Dr. Mansoor, Shahid, Sair. It would have been so wonderful if you could have caught up over some nice dinner at some point of time. I'm sure when I come home next time, I would make it a point to catch up for what I have lost at this point of time. And it's also my duty to sort of, again, as I said, I'll stop where I started, that, head and neck is a multidisciplinary thing. And as ENT surgeons, we are all, we love our one-man shows. We love hospitals in our names. But I cannot do that. I cannot, all the work that you saw is not entirely mine. I have a wonderful group of people. We are working together for 10 years and it's like home there. I really enjoy. And that, when you enjoy your work, it's not work anymore. So Rajiv with me for more than 10 years. Kapila was my student, now consultant. Pratik just joined the ranks as a consultant. Dr. Biswas is a brilliant plastic surgeon. Give him a hole, he will fill it. There's no question about it. You can go haywire with your surgery. Swagato and Sumit, wonderful patient radiologists. You sit with them the whole day on the console. They're ready to help you. Asif puts in all the implants, make sure that all the jaws that we knocked out have teeth in them. You go back eating and chewing your at least your khichdi. That is what they eat in Bengal. And the best part of it is that I continue to read, I continue to learn. It's because of the last 9 years, we are having a very robust fellowship program. And all these youngsters, many of them who have moved out and found their calling elsewhere. For ENT surgeons, it's not a very easy field because, there are not many places to go to. But at least there are some people like Sajid and I have sort of moved into head and neck surgery. And welcome. It's apart from your FES and your ear surgery, head neck surgery is also as interesting and as charming. So thank you so much. I would love to hear from you. I do not know who all joined me for that meeting, but there are friends, there are teachers, well-wishers. So please mail me, just put in a word. And thank you so much for bearing with me for the last 2.5 hours. And Dr. Sandhya, if you have anything to say, I will stop here. And thank you, all of you.
Thank you for patiently listening to.
So thank you, Dr. Arun, Dr. Sandhya, for a wonderful talk. It was very informative for us, and hope we can continue in the future also. Arun.
Thank you, sir. Thank you, Praveen, sir.
Are you coming to Calicut?
I will. When I come next, I'll let you know. I have to. Let's take the chat.
Yeah. The thing is, first the COVID has to go. Then we can
Yes,
join.
COVID has to go.
I don't. Definitely, we have KenCon next year, 2021. Yeah, we are hoping that then September. So definitely we are looking forward because Sandhya ma'am also, because we are hosting next time KenCon State Conference of END. END. This is it will be. Pardon?
After COVID.
After COVID,
should be hopefully.
Hopefully, yeah. That was supposed to happen today. It was dinner supposed to be dinner time. We fixed this day only, but unfortunately that COVID took away everything. Yes.
There is a postcode that you can fill while you go you check out, because we will see we can assess the impact of the webinar series that we had. There is a postcode, kindly fill it.
But it is PNS Europe. It's not PNS. You are muted.
Yeah, it was the old one. They have put it actually. Forget it, no issues.
Forget it. Yeah. Okay.
Thank you, Arun sir, and thank you, Dr. Sandhya, for this wonderful case-based approach. Like it was like all coming from the case, pathology, radiology, and everything was in one go. So it was more interesting with such a case-based approach that you have adopted for this. Thank you very much, sir, for this wonderful time, and for spending the evening with my AOI Malappuram and all the. And I also thank all the participants for making this a wonderful success. Hope the COVID era ends soon and we can have a physical meeting like this.
Sure. Bye-bye.
Okay, if anybody needs YouTube link, let me know. It will be ready within 2 days. So we can see it again.
Okay, thank you. Thank you, Dr. Sandhya.
Thank you.
Thank you. Good night, sir. Good night.
Good night.